Good morning. You're very welcome, or good afternoon, wherever you are in the world. We're really excited to have this webinar on the ethics of clinical research involving children. It's a very appropriate topic at this time and also very urgent. And we have really great speakers to present this afternoon or this morning. The agenda will be as follows. We'll have balancing innovation and protection, the ethical consideration in pediatric surgical clinical trials, ensuring ethical integrity, regulatory oversight in pediatric clinical trials, national perspective, ethical approval and compliance in pediatric research, and then a panel discussion and questions and answers. Please write your questions and answers in the chat so that we can actually be able to address them with relevant speaker at the appropriate time. Joining us, as we can see from the map of the world, are people from all these countries, all the continents, Africa, Asia, Europe, Latin America, and North America, as shown on the map. We welcome you all from wherever you are coming. We're looking forward to a great webinar. So our first presentation, we're honored to have Dr. Erisa Mwaka. Dr. Mwaka is a clinician, academician, and bioethicist. He's an orthopedic and spine surgeon and an associate professor and chair of the Department of Human Anatomy. He's a former Research Ethics Committee chair and member of the Forum for Research Ethics Committees in Uganda. He's a member of the Bioethics Working Group at the National Council for Science and Technology and is actively involved in short course training in human subjects protection, responsible conduct of research, GCP, and clinical ethics. He's a faculty member of the U.S. Fogarty International Center, funded International Health Research Ethics Training, Master of Bioethics Training at Makerere University. He's a co-investigator and coordinator of a PhD in bioethics training at Makerere College of Health Sciences. He is also a PI and senior researcher at MUJO, and is the chair of the H3 Africa Ethics and Community Engagement Working Group. His research interests include research ethics, ethical, legal, and social issues in biobanking and genomic research, clinical ethics, digital health ethics, human anatomy, medical education, and both health. So we're truly honored, and it's a privilege to have Dr. Erisa Mwaka speaking on this very important topic. Handing over to you, Dr. Mwaka, you're welcome.
Thank you. Good morning, good afternoon, everybody. Thanks for such a kind introduction. So today we are looking at a very important topic that people usually talk about, and that's surgical clinical trials. And that's an outline of what we are going to learn today. So historically, children were viewed as vulnerable subjects. As such, pediatric research, research in children was in some countries was prohibited. However, we all now know that pediatric research is now a moral imperative, and in many of the guidance documents, international and national, children and adolescents must be included in health research. The field of surgery, specifically, since we are looking at pediatric surgery, the field of surgery has relied on innovation and creativity to improve patient care and propel the field forward. And historically, new surgical practices largely relied on anecdotal evidence from case reports or case series and knowledge from mentors, like, for example, apprenticeships, rather than following strict standardized processes as we see in pharmacological clinical trials. Now, I would like us to understand who a child is. So, according to the ICH, Clinical Investigations on Medicinal Products in Children, children are categorized in about 5. You have the preterm newborn infants. We have the term newborn infants, that's 0 to 27 days. We have the infants, we have the children, and we have the adolescents. This is very important because ethically, there are responsibilities that parents and the minors themselves have when it comes to research. What I would like us to understand is that children are vulnerable because they lack mature decision-making capacity. They are subject to the authority of others, so they do not live independent lives. And as such, they have, they have to be represented by somebody. And at times a child might dissent, but because they are under the authority of somebody, they might fail, okay, to show their dissent. And basically, in many of our communities, when a child talks, maybe they don't take them seriously because their rights and interests may be viewed as socially unnecessary. Now, there is the principle of scientific necessity in pediatric research, and vulnerable populations such as children should not be included in the research investigation unless their involvement is essential to answer a scientific objective relevant to the health and welfare of the vulnerable population. That's an excerpt from the ICH GCP. We have the Helsinki, then the EMA regulations. Now, from the American Code for Federal Regulation, it also states that children should not be enrolled in clinical investigations unless necessary to achieve an important scientific or public health objectives. And the risks should be minimized, and the selection of these participants must be equitable. Now, that brings in another principle of extrapolation. Now, this is another excerpt from the ICH Clinical Investigations on Medicinal Products in Pediatric Populations. When a medicinal product is to be used in the pediatric population for the same indication as those studied and approved in adults, the disease process is similar in adults and pediatric patients, and the outcome of the therapy is likely to be comparable. So it's, when that happens, then you can extrapolate data from adults to children. But we've seen with time, we've noticed that actually this does not hold for all devices and pharmacological agents in children. Now, the principle of extrapolation has some limitations when it comes to children because it's extremely complex. Okay, and this basically I have limited it to pediatric surgery, extrapolations in pediatric surgery trials. One, children are developing and there is ongoing maturation. Remember, in many of these studies, you have to follow up. There is follow-up. And these children are growing and they are maturing. So basically, even their physiological and anatomical functions and structures are changing. Then many of these clinical trials, usually they're unique diseases, which are rare, and they are also congenital diseases. As such, the sample sizes are usually limited. So when you look at the statistical power, you find that actually the sample sizes are small because there is limited evidence in the literature, especially when it comes to pediatric trials. Then you find that there are variable skills. Different surgeons have different skills. Different different procedures have different requirements. So even the issue of standardization becomes a problem. Then there is difficulty in confirming assumptions. We all know that when we are conducting studies, when we're doing statistical inferences, we need, there are certain assumptions we have to take to bear in mind. Then there might also be a problem with surgical techniques and transferring these surgical techniques to different surgeons. So standardization, as we can see, we'll have to learn later, is also a problem. Now, we have to look at the risk-benefit assessment. The level of acceptable risk for a child in participating in research is based on the distinction between therapeutic research, which provides a direct benefit to the patient, and non-therapeutic research, which produces knowledge without direct benefit. So I want us to underline the words, prospect of direct benefit. So children should not be placed, at a disadvantage by being enrolled in a clinical trial, either through exposure to excessive risk or by failing to get necessary health care. Now, let's look at the different risks. So there are different categories of risks. One, you have risks involving no greater than minimal. For example, venipunctures, chest radiographs. Then we have researchers involving greater than minimal risk, but presenting the prospect of direct benefit. And this is where pediatric research, surgical research comes in. Then there is research involving greater than minimal risk, but with no prospect of direct benefit. This one usually, unless very necessary, usually requires a lot, a lot of regulatory scrutiny before being accepted for involvement of children. Then we also have a waiver of consent or a waiver of assent. And according to the Code of Federal Regulation, this can only be done on de-identified patient information, for performance improvement or for research publication. Let's look at the prospect of direct benefit in greater detail. The risk to which a child may be exposed depends on whether the intervention does or does not offer the child of, prospect of direct benefit. Thus, defining and assessing the possibility of direct benefit is an essential aspect when it comes to ethical acceptability of interventional studies in children. And basically, the individual research interventions and procedures must be categorized and assessed according to whether they do offer or do not offer an approach. And this is a concept referred to as component analysis. So each intervention must be analyzed and justified separately. Now, when you look at the American Code of Federal Regulation 50.2 and 50.3, these two give further guidance on this. And basically, the guidance is principled on the prospect of direct benefit. Now, 21 CFR 50.2 that looks at clinical investigations involving greater than minimal risk, but presenting a prospect of direct benefit. And it states that children may only be involved in such research if the IRB finds that the risk is justified by the anticipated benefit. Then the relation of the anticipated benefit to the risk is at least as favorable to the subject as that presented by available alternative approaches, and assent is mandatory. Now, there is also clinical investigation involving greater than minimal risk, but with no prospect of direct benefit. However, when the study is likely to yield generalizable knowledge. And in this, the risk must be minor, and the intervention or procedure presents presents experience to subjects that are reasonably commensurate with those inherent in their actual or expected medical, dental, and psychological situations. And of course, such a study should yield generalizable knowledge, and assent is mandatory. Now let's look at innovations in pediatric surgery research. Now, there are quite a number of regulatory challenges when it comes to pediatric surgery research. One, there is limited guidance. There is limited guidance regarding the introduction of new techniques utilized in the operation room. Regulatory oversight of innovative approaches to surgery has been largely inconsistent, rendering surgeons relatively unrestricted creative latitude in the operating room. However, this sounds like it's negative. However, it has a positive side of it, because of this, surgeons have a greater degree of autonomy and freedom of creativity. When you're looking at pediatric surgery, there is a lot of room for creativity. And basically, the other regulatory challenge is unregulated innovation, especially when treating vulnerable population. And because of all this, we need surgeons to self-regulate. So there is a need for self-regulation, especially in the face of appealing incentives. Self-regulation of surgeons in innovation is complex. However, it encompasses clinical expertise, ethical decision-making, transparency, responsibility, and commitment to improvement. Now, there are two frameworks that have been put forth. One by Snyder, 2023, and there is also an ethical framework by Schwartz, 2014. Now we are going to look at each one of these. Now the ideal framework, this is a model that involves the generation of a new idea. So this is for basically novel ideas. And when you're developing this idea, one, you have to describe it. For example, in the literature, Alex, it can be described as a case report so that other people read it and understand it. Then after describing it, then you go into the developmental phase, whereby actually this procedure is refined. And the refinement is by surgeons and other centers. However, this requires REC or IRB approval. Then after that, after it has been refined, you go into the exploratory phase where you have to show that it's reproducible. And with reproducibility, it has to be exposed to different surgeons, different centers, so that at the end of the day, information is collected. And this is what I'll call the pre-trial information. Once this is done and it's analyzed, then you can go into the RCT. However, this requires long-term follow-up, whereby there is monitoring of effectiveness, of the new intervention. Now, this ideal network, the framework has limitations. It requires a huge amount of time, results in clinical delays, whereby actually it's not ideal for the emergency setting. Because in emergency setting, you really need to work hard. You really need to work fast. And at times in an emergency, you go in to do something and you find that actually you have to troubleshoot and do something else. And it may not be feasible for small groups. It may stifle the dynamic nature of surgical innovation because it is linear. Then we have the ethical model. Now this ethical model requires that the surgeon has expertise in the field. He has the technical skills to conduct the surgery. He's able to do benefit risk assessment to ensure that the benefits outweigh the risks, and there must be informed consent from the parents. Then he should be able to manage his conflict of interest. Remember, most of this, most of these, especially when it comes to trials that require looking at devices, it's a big pharma, so they have to be able to to take care of the, to manage their conflict of interest. At the end of the day, when you collect the information, you have to analyze it, analyze the endpoints, and identify areas of improvement. Then after, you publish. The ethical model basically views surgical innovation as a continuum that allows for innovative creativity while ensuring the importance of systemic evaluation. This framework was designed to assist in navigating the novel interventions that follow in 3 zones. So the continuum is from practice variations. Now these are variations of practice that is well established. Then you also have experimental research, whereby these are practically new procedures and interventions that are being introduced. Then you have a middle zone, which is the transitional zone. So the transitional zone has 3 categories. You have the type A, where that one is performed spontaneously in response to an acute problem. Then you have type B, where the condition is limbo life-threatening, and there is no adequate therapy or approach that currently exists. Then type C, these are premeditated and planned. So these are interventions that are new. And even this ethical model has to pass through those different phases. The ethical model allows surgeons to self-regulate innovation and safeguard patients without stifling creativity, and can be applied in the emergency setting because it allows for ongoing modification during the trial. So that's a summary of self-regulation, depending on whether it's a practice variation, experimental research, or the transitional zone. So let's look at the ethical considerations. So the first ethical consideration is informed consent, whereby you need parental permission. However, the key issue is that this should be done honestly and transparently. And it has to address the nature, the risk benefits, and where possible, there has to be shared decision-making between the parents, the child, and the surgeons or the researchers, because this foments, it foments patients' autonomy, fosters trust and transparency, and encourages respect for autonomy. Then there is a child assent, and this you have to take into consideration whether the child is capable of providing assent. For example, in Uganda, the child should be between 8 and 17 years. Then you have to look at the maturity, their ability to understand, okay? However, assent may be waived if capability is so limited that it can, that the child cannot be consulted, or where there is a prospect of direct benefit is important to the child's health or well-being, and lastly, when there are just minimal surgeons. Now, there are challenges in informed consent when obtaining consent in surgery, particularly when a surgeon introduces new techniques, because here the risk-benefit assessment is dynamic. Things change, okay, along the way, and additional risks may be introduced, and there is a need, to keep on updating the families. However, at times we give these families are given a lot of information, even technical details that might actually confuse them. Then there are decisional preferences where children and parents have differing decisions. The parents would like the child to participate in this, in the clinical trial, whereas the child, okay, does not want. So these are some of the problems. Then other key considerations, there is limited evidence. We've already said that, there are fewer than 4% of studies published in surgical journals are based on RCTs. And this is a problem. Then there is also investigator bias. Surgical practice is centered largely on individual preferences, and likely low-level evidence or personal experience may supersede scientific validation. Then we also have inconsistent legal frameworks across borders. The law in Uganda and the law in the US might be different. And we know that these ethical and legal frameworks are the ones that govern research. These can also, cause, especially in multi-center studies. When it comes to scientific validity, yeah, we've already looked at, challenges with standardization because the child physiology and anatomy is changing. Techniques are also continuously changing. Then the results vary by surgeons, expertise and technique. And, if it's a new technique, then there is a variable learning curve. You have, surgeons really have to learn, to perform those. Yeah. Then there is also inability to, to conduct phase 1 and phase 2 trials. And that this increases the evidence base. So placebo control trials are all, those ones are so problematic unless this is a totally new condition. Then many of these conditions require long-term follow-up, especially when the child is growing. You might find that you might need to follow up a child for 5 or 10 years. Then you have parental emotional involvement. There are a lot of misperceptions. Others think that when you when they randomized in a given group, they feel that maybe that's the best group. So this introduces a lot of bias, and actually families might have preferences for a certain group or even a certain surgeon, and this actually also causes a problem. Then some parents are not willing to subject their children to unproven and unfair opinions. Then at the end of the day, when the surgical trial is done, there is also availability and equitable access to the innovations. So in summary, pediatric surgery trials are complex and ethically challenging. The enrollment of children in a clinical investigation must be considered scientifically necessary. There must be an appropriate balance of risks and potential benefits. There are gaps in regulation. Thanks very much.
Thank you very much, Dr. Risa Mwaka. That was really an excellent overview of the challenges and ethics of surgical research in children. Thank you so much. This is, I'm sure people have questions and they'll be putting them in the chat. Excellent. We're going to move on to our next presentation, which will be Mary Maria Musisi, talking about ensuring ethical integrity, regulatory oversight in pediatric clinical trials. It's an honor and privilege to have Ms. Maria Musisi talking to us. Worked with her over the last 20, 30 years. She's a compliance coordinator at Muju Care Limited. Before that, she was heading the regulatory affairs. With over 30 years of experience in nursing, clinical research, and regulatory affairs. She has played a central role in strengthening compliance and research ethics in Uganda, particularly through her long service at the Muju Research Collaboration, Kampala, Uganda, where she also serves as a HSP, Human Subjects Protection, and GCP, Good Clinical Practice Trainer. She's certified trainer. Is working as a Research Ethics Committee voting member with Uganda Cancer Institute's Research and Ethics Committee in Uganda since 2015. Ms. Musisi has been instrumental in building the capacity of research ethics committees across Uganda, as she supports the Uganda National Council for Science and Technology, Bioethics and Human Subjects Training for research ethics and research team trainings, and has supported numerous institutions in Uganda in ethics and compliance training. So we're really excited to hear from Ms. Maria Musisi, who has a wealth of experience in implementing clinical trials, overseeing the research. Over to you, Ms. Musisi.
Thank you very much, Professor Philippa. Good morning and good afternoon to everybody. I hope I'm audible enough.
Yes, you are.
Yeah, so we are going to look at ensuring ethical integrity and regulatory oversight in pediatric clinical trials. And so that is going to be my outline. When you talk about regulatory oversight, they vary from country to country. And for this presentation, I a little bit focus on Uganda's clinical trial oversight. And in Uganda, it involves a number of regulatory bodies with the distinct complementary roles. So we have the Research Ethics Committee that are created by UNCST, which are responsible for safeguarding the rights, well-being, and protection and safety of participants. Then we have the National Drug Authority that serves as the National Regulatory Authority. And this is responsible for overseeing all clinical trials in the country. They grant approvals. Then we have our umbrella body, which is Uganda National Council for Science and Technology, that was established by an act of parliament. And then we also have the National Health Research Organization that works alongside with the UNCST and is mandated to formulate the research agenda in Uganda. So when we talk about pediatric clinical trials, this is established through multiple legislative instruments and guidelines. So when we talk about Uganda, you talk about, I know different countries have different framework, but I will talk about what I know and what I've worked with. So we have the National Drug Authority, which has an act, and it provides the foundational legal authority for the research activities, and it details specific requirements for clinical trials. Additionally, Uganda is party to international agreements that influence clinical research regulation. You can talk about the Nagoya Protocols on access and benefit sharing, which has implications for studies of investigational products. So when we talk about compliance, we need to be compliant with both national legislations and international agreements when designing the conduct of pediatric trials wherever we are. So when we talk about ethical considerations, we need to be thoughtful about the legal requirements. We know that in pediatrics, children are vulnerable. Usually, they lack full capacity for autonomy and decision-making. And this necessitates additional safeguards in research. So we know the guiding research principles, which includes the principle of beneficence, which states that children should not be exposed to research risks when the study offers a prospect of direct benefit or when the risk is minimal and justified by the value of the knowledge to be gained. And I guess Dr. Erisa has expounded a lot on this. So the ethical frameworks, including the Belmont report, specify that pediatric research should not expose children to more than minimal risk unless it holds potential for significant therapeutic benefits. So here, we are supposed to make sure that research without direct benefit must be justified by its potential to improve the health and well-being of children in general. And here, these principles are rigorously applied by the regulatory framework, where we have the ethics committee, which are responsible for reviewing proposed pediatric studies. And I know worldwide, the Research Ethics Committee, or sometimes they are called, in other places they are referred to as RBs, in other places they are referred to as ethics committees. They are responsible for ensuring that they review pediatric protocols before any study is conducted. So we have ethical consideration that should align with global ethical standards. And here we talk about informed consent process in a pediatric trial, which is more complex than in adult studies. And again, here you are thinking about the legal limitations on children's capacity to provide assent. And you find that when you are talking about assent in children, it's very critical to think about the process of translation. The child we must use an assent that has been well translated and to the education level of the child. And this, before you go to the child, and a consent must be obtained from a parent or legal guardian. And again, we need to consider the age at which children can assent, and it varies. In Uganda, it is between 8 years to 17 years. When you look at our National Council guidance, they are specific. When you go to section 5.0, it talks about the age at which children should be assented. So for trials involving adolescents, when a child that was assented transitions to adulthood, they turn 18, the researcher must ensure that this child that has transitioned to adulthood signs a consent that must have been approved by the ethics committee to ensure that now they are adults and they are voluntarily agreed to take part in research. They have reached the decision-making capacity. The other thing that is very important is to minimize discomfort. And this includes addressing physical pain, psychological distress, and disruption to daily life. So again, when the regulators are looking at these protocols, there are certain aspects that they need to pay attention to. So protocols should incorporate strategies to reduce discomfort during procedures. For example, when you are drawing of blood, imaging studies, or drug administration. So I wanted to bring out some of the few things that should be considered, like effective risk minimization. So for example, topical anesthetics before needle sticks, so that you reduce pain, using indwelling catheters to reduce multiple vein punctures. Then again, sometimes we have distraction strategies and caregiver presence to reduce anxiety. So when you are doing an assent or you are conducting any procedure, you want the caregiver or the parent to be around. Then micro-sampling techniques that has helped reduce on blood volumes. Then child-friendly settings and trained child life specialists. Children needs to be handled well, and they need some people who are specialized in those areas to make sure that they are comfortable as research is being conducted. Then there is issue of flexible protocols sensitive to school routines and family burdens. So if a research is enrolling school-going children, you don't want, as a researcher, to disrupt children during class time. So how do you work? What flexibility do you have in place to ensure that you are sensitive about the children continuing with their school activities without much interruption? So working with the school calendars is very important. Then the ethical guidelines mandate that risk must be minimized and reasonable in relation to potential benefits. So here the ethics committee play a crucial role in evaluating protocol risks. Again, as regulatory bodies, as research ethics committee, they are responsible to ensure the safety of research participants, and they must assess the risk category. And usually this is required to be documented in research, such that any reviewer can see and check that the risk category was assessed and documented for a particular protocol. So in terms of submissions, again, an example of what happens here, we submit to the Research Ethics Committee, and then the researcher submits to Uganda National Council for Science and Technology, the umbrella body that oversees research in Uganda, the National Drug Authority. And usually we may have another step of institutional administrative clearance, whereby if you are going to recruit from hospital A, you need to get gatekeepers' consent from that hospital, the hospital director, to give you permission to use their premises for research. So I have a line listing of some of the documents that are mandated to be submitted for review and approval, like the protocol with specific pediatric considerations. We've talked about the risk categories, the investigators brochure, informed consent and assent forms. Again, the assent should be age appropriate. So you have the parental consent, and then you have the assent for the child. Again, the assent, the amount of information in the assent should be in line with the age of the child. Then the clinical trial insurance. For every clinical trial, we need to have an insurance. Then investigators' qualifications, of course, that is going to be assessed by the curriculum vitae that is submitted to the ethics committee. They use that to evaluate investigators' qualification, expertise, and training. Then site suitability documentation. Again, that is supposed to be part of the submission. Then we have the clinical trial application. When we are submit to like the National Drug Authority, they have 17 requirements that we must meet. Then there is requirement for material transfer agreement if a study is to ship samples for future storage or for study-specific tests. Then the data collection tools, of course, the IRB will only make a decision if they are sure that the data that's going to be collected is in line with the protocol that has been submitted. Then the risk management plan. The risk management here you are assessing the risk to the participant, the risk to the institution. So these have to be assessed. Then the data sharing agreement. This is an agreement that is supposed to be signed between the sponsor and the PI, and they are supposed to make a good decision of how data is going to be shared. Then the community engagement that is done before I start the submission and implementation to make sure, again, most of these we have guidelines that talk about how they are supposed to be handled. So when the Research Ethics Committee or regulatory bodies receive the application, they check for completeness and determine whether the application is complete. And here, usually, if it's not something is lacking, they may go back to the PI to request for more information. And then after that, it will be lined up for either internal review, expert review, or joint reviews. Following review, the Research Ethics Committee may authorize the trial and issue an approval letter or request for additional information or make recommendations. And sometimes the application may be rejected because when you are dealing with children, there must always be justification. So I want to talk about challenges. And one of the challenges that we have when we are conducting pediatric clinical trials, I will start with something that is very pertinent in research, and that is the issue of documentation. When we are, and it's like for all other studies, documentation is key in research, and it is the documentation that will be evaluated for the conduct of the study. So the other challenge is infrastructure and resource limitations. So here, there are several practical challenges. And this may be exacerbated by limited healthcare infrastructure outside major urban centers. And sometimes we have limited specialized equipments that are needed for pediatric research. The other thing is funding limitations. As we know, globally, only 4% of cancer research funding is designated for pediatric, and similar disparities exist for other disease areas. So there has been a recent change, and I think all of you will agree with me that we have had a major shift to NIH grant funding, and this has reduced resources available for pediatric clinical research. Then we have another challenge of ethical and cultural considerations. it is very important to navigate complex cultural considerations regarding consent, the authority structures. When you go to families, who should give you permission to have their children in the research? So we have those authority structures within families, then we have those ones within communities, and then, of course, that can be handled when you are conducting community engagements. And then we need to make sure that they develop culturally appropriate strategies that respect local traditions, while ensuring understanding of research concepts. So a lot of work has been done in research, but you find that most of the populations or in the communities, people are not clear on the research concepts. So how do we have a language that is going to be well understood by our communities to make sure that as research comes in, they will approve the research, and they will also ensure that when results come out, we talk about sustainability. Then we have the scientific and methodological considerations. Children metabolization rates are different. The test preferences, as we all know, we have been children before we grew to adults. Then the ability to swallow medication. I know even as I talk, we have among us the people who are on this call, you may find that there's some of us who have been given medication and we have not taken it all. So we need to think about the children's age across the different groups and think about their developmental stages. So we need to ensure that pediatric research should account for physiological differences among pediatric age groups. For example, you think about neonates, we talk about infants, children, and adolescents. And the test, in young children, the test of the drugs, sometimes some syrups are not good they don't feel well to the test. And I think before we give drugs to the patient, to the children, it's important to know how some of these drugs test. Sometimes I feel it's too much. So these are best practice and recommendations. We need to have patient-centric protocol design, and this that should minimize participant burden while ensuring compliance with regulatory and ethical requirements. So the protocol design should incorporate decentralized and hybrid elements tailored to different pediatric age groups and leverage early feedback from patients and caregivers during development. Then the issue of community engagement and trust building in the communities is also very critical. So again, this should be beyond individual trials, including post-trial access to beneficial interventions and capacity building for local researchers and institutions. Then the regulatory compliance and monitoring, safety monitoring is very critical to ensure that the children are safe that are taking part in research. We have the DSMBs that do that, but I think on the ground, we need to make sure that we have critical monitoring when we are conducting research in children. Again, we need to ensure that we plan for post-trial continued access to investigation products that demonstrate benefit, addressing this ethical obligation before a trial initiation. These are references that I got some of these things from, this work from. And so for the acknowledgements, I would like to acknowledge SNIP Africa, acknowledge the Research Ethics Committee. Oh my God, the slides are moving fast. We also thank the pediatric patients and their families who participate in clinical trials to advance medical knowledge and improve care for children worldwide. And thank the protocol team staff, sponsors, PIs, and team staff that adhere to the research principles during study development conduct for protection of pediatric trials. Thank you.
Thank you very much, Ms. Musisi, for that experience and taking us through the regulatory framework and the ethical framework to make sure that we adhere to the ethics of conducting research in children. And obviously there are multiple challenges that we're going to address. I hope people have been able to put some questions in the chat. I'm going to start with the questions that are directed, first of all, to Dr. Erisa. The first question is, thank you for the insightful presentation. This is Tesafeyu Gelaniu. Dr. Erisa, as an experimental study, is it mandatory for the intervention, could be surgical or a drug, to be studied in adults before it is applied to children? Dr. Erisa.
Thanks very much. Hope you can hear me. So specifically, when you are talking at pediatric trials, like I stated, there are quite a number of limitations of extrapolating data or information obtained from adults to children because of the different, anatomical and physiological nature. However, there are some procedures that have been done in adults and can be extrapolated in children. Yes, they are there. But the problem is, at times, they are different, you need to follow up these children for quite some bit of time, and they are still developing. So you might find that actually 2 years, a follow-up of 2 years can change a lot. So I think I've answered your question.
Okay. The second question is from Jacqueline Aikoru from Uganda. She's talking about the age of ascent, which is 8 to 17 years in the presentation. And she said, are there any special consideration for the same age group of children who are considered emancipated minors? We'll have Dr. Risa Mwaka first, and then Ms. Maria will also add. Dr. Mwaka.
Thanks very much. Actually, I was typing an answer to that question. When you read the current Ugandan guidelines, they talk about the mature minors and the emancipated minors. When you read other international guidance documents, yes, they are mentioned. But in Uganda, in the Ugandan constitution, there is nothing like a mature minor and emancipated minor. That's why right now the Ugandan national guidelines are under revision. However, mature and emancipated minors are not supported by our constitution in Uganda, and actually they shouldn't be. They shouldn't be mentioned in the national guidelines per the law. However, operationally, yes. If it's a teenage mother who's taking care of themselves, maybe if it's a child, maybe 17, a head of household, yes, those are emancipated minors, okay? And actually, they can consent for themselves. But by law, in Uganda, that's illegal. Thank you very much.
Thank you so much, Dr. Mwaka. Madame Maria Musisi, can you add on to any of that? Because we've had to deal a lot with that in our studies in pregnant.
Yeah, I can say that in addition to what Dr. Elsa has submitted, you want to call them mature minors. But again, depending on the research study in question, you also want to make sure that you can have those mature minors that are living independently. So by research design, this should be clear, and the ethics committee should be able to evaluate the risks and benefits of this study to this age group. The other thing that I wanted to add is that when you are developing an ascent again, it would be good to have, when you think about an ascent for an 8-year-old versus an ascent for a 17-year-old, I imagine that the information that you are going to put in an 8-year-old is going to be different from the information that you're going to put in a 17-year-old. So again, it is very critical that you work hand in hand with the ethics committee to come up with the best practice and the best information to give the different age groups. That's what I can add, Professor.
All right, thank you so much. Another question which has come up, I think we can start with you, Maria, and then Dr. Mwaka can add, is about if you have an assent and the child agrees to the research, but then the mother or caretaker parent refuses, in such a scenario, what do you do as a research staff?
The regulation is clear that before you talk to the child, you want to talk to the parent first. So if the parent refuses, you as a researcher will not have access to talk to the child because the parent has refused you to talk to their child. So if a parent refuses, then you will not have any research documentation pertaining to this child's assent. That's what I want to say. Yes.
Okay. Thank you so much. Dr. Marker, did you want to add anything?
No, maybe whatever she said is accurate. If a parent says no, then you have no business talking to the child. However, if the parent says yes, okay, I consent to the child participating in a study, and the child refuses to assent or dissent, then the child's the child's decision, is respected. But if the parent has not yet given you the permission to talk to their child, then you have no business, looking for assent. Thank you very much.
Thank you so much. Now, a question from Mohammed Daudi Farao. It's compulsory for all research that the patient under 18 to get direct individual benefit, or can you please talk about different benefits in research? Dr. Marker?
Okay, thanks very much. You see, we have this concept of prospective direct benefit. You find that actually this is in the regulations. I mean, in the regulations, whereby the regulations demand that for research involving more than minimal risk, the research should have direct benefit to the child. However, if the research does not have any direct benefit, then it should be minimal risk, and such a research should generate generalizable knowledge. But in both cases, child assent is mandatory. I think that's briefly, that's how I can summarize it.
Okay, thank you so much. I see Mr. Sam Ogwang is available now. Before we go into hearing from Sam Ogwang, your hand is up. I just wanted to say, the neonatal research or childhood research when they're infants, as we've said in the presentation, it must benefit the child. But sometimes the mother or the caretaker the child is very sick. And so the ethics of conducting the research are sometimes sort of difficult to compare with getting the consent and then also ensuring that the caretaker is taken care of in terms of understanding what the research is about. And so the balance of doing emergency research and also ensuring the caretakers are taken care of. If you could just give a short comment about that, Dr. Marker, and then we move on to Dr. Guang. I'll hear from you.
Okay, thanks very much. Like I said, in many of these pediatric surgical trials, usually either it's a rare disease and they're looking at how do we treat this disease, okay? Or it might be a congenital anomaly, okay, whereby actually you need special equipment and special expertise. So you find that actually, especially, and if you
The internet.
I would like to add that most of these congenital anomalies, some of them actually are. I'm tethering using my phone, and somebody was trying to call me. Yeah, sorry about that. So what I'm trying to say that in these pediatric surgical trials, at times you want to work fast. And then the other thing is, as you work, remember these are mainly, rare or new diseases or congenital anomalies. At times you set out to do a procedure, but midway, like any surgery, you have to change. You have to change, or you have to adjust the adjust the technique. And in this case, it affects the standardization. So you might find that you have about 3 different participants operated successfully, but with relatively varying techniques. So pediatric surgical trials in children are a bit complex. I won't say that there is a right and wrong answer, because there is a lot that has to be taken into consideration. Thank you.
We're going to hear from Mr. Sam Ogwang, counsel. Let me just introduce him before we hear from him. Thank you so much for joining. Sorry about the challenge with the internet. Let me introduce Mr. Sam Ogwang. We're honored to have you here, counsel. He has a Bachelor of Law, Diploma in Law and Legal Practice, Alternative Dispute Resolution and Court Annex Training, and Registered Mediator. He's an enrolled advocate of High Court and subordinate courts of Uganda. He's a member of Uganda and East African Law Society with working experience in legal corporate service delivery, policy development, compliance, and implementation. And he's with us representing research. He's a research integrity and legal advisor for the Uganda National Council for Science and Technology. You're very welcome, Councillor Ogwang. Over to you.
Thank you so much. I hope I am being heard very well. I don't know what's happening with my camera.
We can hear you, sir.
Yes, thank you so much. Sorry that whatever has happened has caused some confusion that I did not follow up the discussions. But we thank God that we are together. For the interest of time, I have been already introduced. I work for Uganda National Council for Science and Technology. And my area of interest is ethical approval and compliance in pediatric research. And we are looking at specifically the national perspective. That means we are looking at the scenario of Uganda. How does the issues of ethical approval and compliance in pediatric research take the shape? So I have looked at it in some dimension. Yes, thank you so much. I have looked at the topic in those 9 areas. I have an introduction, which just tries to give an overview of my presentation, which relates to the pediatric research approvals, ethical approvals, and compliance in Uganda. And then the purpose of the presentation, what I want to make sure that the participants take home at the end of the presentation, that those are 2 specific objectives. And then the legal framework for the clinical pediatric research in Uganda. By legal framework, I mean the laws and the institutions that are being created by those laws that support the clinical pediatric research and compliance in the country. Number 3, I shall look at the relevant stakeholders to this ethical clinical pediatric research and compliance. And then I shall have the processes that are involved for this ethical approval and compliance. Number 5, I shall look at the best practices. And then number 6, the misconduct, the wrongs that take place in this clinical research approvals and compliance that involve children. Sometimes there can be cases, there can be violations here and there. I will look at the achievements that we have registered as far as clinical research approvals and compliance in Uganda is concerned. I shall also have briefly the challenges to the ethical approvals and compliance in Uganda, and then I shall try to suggest the way forward. Maybe you can directly take me to, we can directly go to the legal frameworks, because I've already done with the introduction, which is an overview, the purpose, the objectives. The legal frameworks, like I had already made an observation, comprises of two hands. We are going to look at the relevant laws, international and national, that support ethical research and compliance in Uganda. And then those laws come up with institutions, including committees that have some work as far as this research is concerned, especially on two aspects that I have said I will be interested in. That is ethical approval and compliance. We have international conventions like the Declaration of Human Rights, which talk about the dignity of persons, which includes children, the Convention on Ethical and Human Rights, the Constitution of the Republic of Uganda, the National Drug Authority Act. It also has the regulations there which deal with specifically the conduct of clinical research, conduct of clinical trials. This one establishes the authority which deals with the research that involves the drugs, the products, and their quality in Uganda, which actually relates to children especially. We have Uganda National Health Research Organization Act, the UNRO Act, which establishes also the UNRO and their roles to deal with the research that relates to public health research. Then we have Uganda National Council for Science and Technology, the Act, which establishes Uganda National Council. We have Children's Act. We have national guidelines for research involving humans and as research participants, 2024 as revised. There is a new revision like it has already been observed. Then we have guidelines and policies for research clearance. This is what Uganda National Council uses for clearing research and registering research. Then national accreditation guidelines for establishing a national accreditation committee, which leads in planting, establishing, accrediting the research integrity committees in the country and their training. So that law is very important. National guidelines for community, this one's define engagement of the community into research 2022. National research, biobanking guidelines, personal data protection. This deals with the personal privacy related data, their protection. And then we also have things to do with the presidential directives, amongst others. All these laws have a role to play when we talk about clinical research or trials which involve children. They establish the institutions, and after establishing the institutions, they also provide the necessary and relevant approval requirements and the compliance issues. What I want to observe is that the aspect of ethical approval and compliance is a creature of the legal framework. It is created by the law. When people are firing patients, I was hearing them. The whole thing, what we needed to do, the compliances we needed to do, and the ethical approval that we need to go through, the timing, everything is governed by the law. That's why I have decided to call it a creature of the statute. It is given birth by the law. So these are the laws. Below it, number 2 are the institutions that I was talking about. Maybe I can be taken to another level. Another slide. So these institutions include Uganda National Council, which is established by an act. Among the roles that it plays, it oversees and coordinates research and development in Uganda. It clears the research. That is why it is termed according to the Uganda National Council Science Technology Act, Chapter 206, the one which was made in 1990. It terms under section 4 and 5 Uganda National Council is a clearinghouse of research. So, and information. It does not oversee and coordinate research development alone in Uganda. We have a number of institutions, like I already said, at the ministerial level. There is science, technology, and innovations, innovation, office of the president, and we have a secretariat there. Normally, the council, Uganda National Council, liaises with it before clearing a research. So there is that at a ministerial level. Below the ministerial level, Uganda National Council also collaborates with the NDA, National Drug Authority, collaborates with the UNRWA, like I had already said, Uganda National Research Health Organization, which deals with the health research in Uganda. And after, normally those are the three institutions that, as far as the research that involves children are concerned, their approval and compliance, those are the major institutions that collaborate with the Uganda National Council. From those institutions, we descend down to the committees. Go down again. I have already finished this. We go down to the committees. We have our national committees. I talked about accreditation committee. It has a role in establishing research ethics committees in the country. It has a role of building their capacity together with the Uganda National Council. There are recs that are established by the CRECU. Of course, there are also those that are related to animals. But as for now, I may not talk about them. Then national biosafety committees. These ones deal with the biotechnology and biosecurity matters under the Uganda National Council. This is also a national committee. There are also institutional committees, like Maria had already talked about them. All these still follow within the legal framework. The other slide. This is a community advisory board. Remember, we talked about the role of the community in the research. So there is a law that establishes them, but also there is a committee, a board, which is established legally and to do with issues of community engagement. They support in the work of community engagement. They are termed as the legal opinion wise council providers in the community. You cannot do research without them. And then the other one is, after that, the other legal framework. Let's go to another slide. I have already talked about biobanks. There are also committees that relate to biobanks in case there are specimens that needed to be kept. Some of them are certified, and these are committees which are responsible for such biobanks. And remember, in this ethical approvals, there might be some specimens that need to be kept for some time. We go to another slide. These are the relevant stakeholders, like I had said. These are the persons, individuals, or institutions with corporate entities who have a role and or responsibility to play. This include, among others, I have given just a few examples here, include researchers, includes principal investigators, includes their institutions of affiliation. It includes the regulators, like Uganda National Council in Uganda, who is responsible for the oversight and the coordination of research and development in Uganda. It includes Uganda National Council is a stakeholder. Agencies I already talked about to them, research agencies I talked about to the NDA, I talked about to Health Research Organization, and various committees which I've also talked to. They are stakeholders. Parents, because of the issue of children, you cannot ignore parents. If parents are not there, the research that involves children might become very complicated. These are some of the ethical clinical research approval processes and compliances when you are talking about research that involves children. It is supposed to be a two-tier process. at the institutional level, we have the research ethics committees. After you have been cleared from the research ethics committees, which have also a full pack of the issues that they look at, like Maria had already talked about, for them to clear the protocol. They look at very many things, which I might talk later if time allows us. And then after a clearance from the research ethics committee, a researcher proceeds to register the research and receive a certificate to carry out the research. Sometimes, if it is a research which relates to clinical trials, the law requires that you get a authorization from the NDA, Uganda National Drug Authority. You are supposed to get a authorization from there before you proceed. And when we stick on these principles, that is when our work can become easy. Madam Maria talked about forth and back of the approval processes. The application can go to the research, but it comes back to a PI, goes back to a research because of some issues which are not articulated very well in the research. Maybe a research has gaps. So, but after approval, it is directly goes to Uganda National Council. Application is online to Uganda National Council for Science and Technology, which will register and issue the researcher with a certificate for carrying out the research. And that is sufficient for the research now to begin. But before the council does that, like I had already said, it connects, it does it in liaison with the Science, Technology, and Innovation Office of the President Secretariat. And then the certificate, for a certificate for a permit for research conduct is issued out on the name of the research applicant, but sometimes with some conditions. So that is the process, but within the process there are a number of requirements that are needed, beginning from the research ethics committee. These are some of the requirements. They will need you to obtain the consent from the research participants or assents. Normally, the assent always is from the children who are from 8 years and above. That is between 8 and 17 years. Below that, it shall be only for the parental. Sometimes not a parent, might be an authorized legal representative. Assuming the parents are not there, maybe there is a person who is allowed by law and customs to take care of the child on the footings of a parent. Sometimes there are re-assents, especially if the data assent was taken and the data was kept. And then at a certain age, maybe you want to use that data, there should be a reassent. Probably the child has also attained the age of 18, and when we want to do it, use that data, we have to re-assent the child. Normally, the waiver can be done, and it must only be done by an order of the court. Some people are asking, what happens if the parent refuses to consent? Probably the only way forward for you now is maybe ask court to waive, but without it, you cannot. But if a court gives you a waiver, then you can proceed without the parental consent. Let us go. Other compliance issues may include community engagement, obtaining and complying with the data protection and sharing, use agreements, material transfer agreements, maintaining privacy, that is confidential. Those are confidentiality issues, monitoring and reports by recs or committees to the relevant persons or institutions or the committees about them. For example, PIs can give progress reports to the REX committee. Monitoring or compliance audits may be done by Uganda National Council for Science and Technology, and also the REX. These are some of the practices, best practices that we have employed, that we have seen working in Uganda. We encourage partnerships and collaborations through documentation like agreements or MOUs, the formation of forums such as annual National Research Ethics Conference called ANREC. For our information, it is scheduled for next month, 21st and 22nd, at Hotel Africana. This is a forum which is very important, where chairpersons of the REX are sharing their experience in Uganda. The council has already planned for it, and we are encouraged to attend, because it is one of the best practices that are very important, where we are having a forum to share. There are good practices like open whistleblowing. You allow the people are allowed, the Ugandans are allowed, stakeholders are allowed to secretly communicate to the responsible entities, responsible committees or research ethics committees, including Uganda National Council, on the violations. So this is also a very good practice, and it helps us so much in Uganda to look into those abuses, to investigate, to move down, to do audits, and so on and so forth. Applications are online. This application for registration and the issues of the permit, it is supposed to be an online dispute resolution. We have adopted what the government has put. We allow out of court and at court, that is litigation, alternative dispute resolution or litigation. Those are some of the best practices. Misconduct, research misconduct is always very common, has been very common here and there. But they include the conduct of clinical research without relevant approvals. Some people do that, struggle to make sure that before even getting relevant ethical research approval, they're already there doing their research. Or after getting the approval, they don't move to the national level to make sure that their research is registered and a permit issued. That is a misconduct. Non-compliance to the legal framework, such as personal data protection, confidentiality, or conduct of research without obtaining prior informed consent or assent, or reconsenting sometimes, where research proposals have been corrected, research proposals have been amended. There should be a process of reapproval, applying to a REC again to consider all those areas of the protocol, research protocol, which have been amended. Sometimes the researcher can continue without bothering to make sure that the changes which have been made to the protocol go back to the research ethics committee. Approve the research protocols non-conformity. Some people proceed without following the protocols. Yet you are supposed to observe. With failure to strictly observe the material transfer agreements, research permit conditions, data transfer agreements, consent or assents, and consent requirements inter alia. So there is always a failure. We are supposed to respect the MATs, the MTA so much, because they also constitute kind of a smaller contract that we enter in, and they bind only us. Normally, when we consent through an agreement like this one, sometimes it relates to confidentiality. But of course, we know confidentiality under the law, the Children's Act, and our Constitution. There may be compulsory disclosure where the law requires, or through an order of the court. Then you might be needed to go beyond just confidentiality. Research that is conducted in a wrong manner may lead into litigations, appeals, disputes or conflicts, and the parties may be the STI institutions, all science, technology, and innovation institutions. Corporate entities, maybe partners, those ones who are supporting us, maybe researchers, maybe individuals, maybe sponsors, or even people who have public interest in litigating. Normally, there are people who the law allows, especially our constitution, allows you to take an action, maybe a court action, because you are seeing the rights of somebody, some other person are being violated or threatened. Then you take a legal action, even when they are not your rights, it's another person's right. So all of these people may be involved in a case, assuming there is an issue of misconduct. The remedies may include the fines for you who is found misbehaving, doing misconduct for research, imprisonment. It might be both a fine and imprisonment, maybe suspension of your ongoing research. Sometimes it leads into termination, or cost and compensation are awarded. So we need to know the things when we fail to comply, because compliance, like I had already said, is a legal concept that cuts across. It cuts across to the regulators, even to the researchers, to all the participants, and it is throughout the research progress, throughout the levels of research. Does not matter whether you are seeking for approval, whether you are going to implement, you have got the approval. There are always components that require you to comply. So compliance is a creature of the law. If you violate those, that is what happened. These are some of the achievements that Uganda has registered. An elaborate legal and institutional framework, I have already talked about it. There are very many laws that are put in place. There are very many institutions well coordinated that have been put. There have been also capacity building programs, awareness creation, effective reporting and compliance audits, positive government support. For example, margin of a presidential directive to Uganda National Council to be a regulator for all aspects of science. And then setting as apart a department or a secretariat in the STI, Office of the President, independent and furnishing it very well. Challenges are there. Science is running too fast. Science is running too fast. Ever-changing science atmosphere. Sometimes they are taking off at a faster rate, leaving other institutions behind, including advocates like us. Even, by the way, some courts are lagging behind a bit because technology is running very fast. And although it is positive, it also has a negative part from it as far as the researchers and their approval, which relates to children in Uganda. Sometimes there is a difficulty in identification of authorized representatives. Remember, we said there must be parental consent for a child to participate. And here, a parent may be very difficult to get, may be hiding, especially where the birth of the child has come through a wrongful act. Sometimes the parents run away and hide, and you are going to look for that parent again, mentioning that child. It becomes very difficult for you to get that child. Sometimes it's confusing. Some people look at children who are taking care of others, children who are heads of families, and term them not children. Yet in Uganda, the issue of a child is determined by age. Does not matter even when you also have another child. Even when you are married, you are still termed a child, and the law must be taken on you just like a child. There is difficulty in meaningful application of the vast legal frameworks and the institutions, like I said, because the laws are many. Sometimes we concentrate on the few and leave others. When the law requires something for you, are not understand because the legal framework is a bit vast. Challenges in obtaining permission from community leaders, especially cultural, and or parents and authorized representatives, consents who often believe in the vulnerability and incapacity of their children to provide the consent. Sometimes traditionally, they may be believing that the child is permanently unable. Why should they again ask the child? Let me only do it. And always when you are taking that direction of wanting a child, also they will try to dodge you here and there. and the research may flop and take long. Some recommendations are here, not many, but it's just a handful to tickle our mind to think more and more. Creation of more partnerships, collaborations, and forums for STI, and especially for research involving children. We need more partners, we need more collaborators, such that we do together, we share ideas together. Emphasis to be built along with digitalization. We are finding sometimes difficulty to use both and online, and you are looking at digitalization, you're looking at paperwork. So it's a bit confusing. We need to build systematically and strongly into the digitalization. So probably everything on ethical approvals and compliances shall be done maybe online. Effective reviews and development of forums for pediatric researchers. The reviews, sometimes when we develop a forum, we remain there, no new ideas, no what. The same way maybe a forum presented last year is the same way it's presenting forever. We need effective reviews, we need development, we need new ideas, innovations in these forums. Robust and vigorous awareness raising, community meaningful participation, and continued capacity building programs are also some of the recommendations that are necessary. So these are just some of the recommendations. It is not all, but these are some of the recommendations. Thank you so much.
Thank you very much, Councillor Gwang. We appreciate the discussion from the legal framework and the National Council for Science and Technology. We have a few minutes for maybe a few additional questions. Some people have already left, but we may have some questions to discuss. I think one in particular, which we didn't discuss from the last time, is compensation for adults, the child and the caretaker or the parent, whether either one of you can address that issue about compensation. Or should it be the mother, or should it be the child? It should be both of them.
I answered that in the chat.
Oh, okay.
And what I typed is that this depends on the age of the child, the regulatory guidance, and IRB approval. For children that do not qualify to consent, and that's below 8, then the recompense is given to the parents. Now, for the adolescents, ideally, the recompense should be given to the minor. However, there are certain people who will say that, for them, they do not expose their children to man at an early age. However, oftentimes there is a need to have a discussion between the minor and the parent to decide who should be given the recompense. Now, when in doubt, you seek guidance from the Research Ethics Committee. It can guide you. It can guide you on this. So there is no hard and fast rule, on who should receive the recompense. Thank you.
Thank you very much.
Maybe to add on something very brief.
Yes, please.
Legally speaking, when taking a decision about a child, the law requires that the interest of a child should be of paramount importance. That is the welfare principle. I think it should guide, and that is what a doctor is trying to discuss, the welfare principle of a child. We are looking at whether customary or state, we are looking at for the best interest of the child. So the welfare principle always takes precedent. And by the way, our national laws respect traditions, norms, and values, and which are positive. So the consultation with the parent is also on the other side customary, but it has found itself into the legal framework. So it shall be determined in the best interest of the child.
Thank you very much. We have another question from Kristen Stalker. Can you elaborate on the recommendation related to emphasizing digitalization? I think that was for you, Dr. Gwang, emphasizing digitalization. No, actually, Dr. Mwaka, sorry. Kristen Stalker has corrected in the chat that she wanted Dr. Mwaka to elaborate on the recommendation to emphasizing digitalization. Dr. Mwaka, please.
I haven't talked about digitalization, so I'm not so sure what is meant by and the context in which digitalization is used.
Okay. Would you like to just give a comment, or we can ask Dr.
I don't know.
Gwang?
Is it typed in is it typed in the? I need to read the question.
Yeah,
Is it typed in the chat?
Yeah, it is. It initially says Dr. Gwang, but then she corrected and said Dr. Mwaka. But any one of us can answer.
I think I talked about it.
Dr. Gwang.
Maybe I can say something about it. The context I talked about it is when I gave an example of Uganda National Council for Science and Technology, registration of the research and issues of the permit application is online. It is not a hard paper that a PI may carry from up country, from whatever the other end of the country to where Uganda National Council is for registration and approval. That is the online I was trying to mean. If this process can move down, not only to Uganda National Council for Science and Technology, probably it would help us save time. Remember, issues of compliance, however, in the time, like Uganda National Council for Science and Technology only has 14 days to make sure that application given in is processed and probably the permit is issued. Imagine doing it manual on paper. Maybe it would go to the regs. The regs probably can also conduct their reviews, their scrutiny of whatever documents they want, probably on digitalization aspects, other than just entirely on paper, such that at the same time, remember, they also have compliance of 60 days. So I think I was meaning, I used digitalization to mean, why don't we have probably advance of technology to include some of these reviews to be done online.
Right. Thank you so much.
Maybe Prof, to add on something. I mean, digitalization has quite a number of advantages. One, yeah, it's very important in ongoing, compliance monitoring. Both peri, and post. Post approval. It reduces the turnover time. Then it also enhances, the tracking of of the conduct of implementation of research. And of course, when people know that they are being monitored and tracked, then indirectly there is better compliance and responsible conduct of research. Thanks very much.
Yes, thank you very much. I think Maria can also say something about this digitization, because we've tried over the last 20, 30 years, we've moved from giving in paper-based documents, the protocol, the consent, to the regulatory bodies, to the ethics committees and national council, and you have major loads of paper. Now the ethics committees can be sent digitally, electronically, and even the responses are given electronically. Maria, do you want to give a comment on that, how things are?
Yes, Professor. I just wanted to say that, like 10 years ago, we are submitting tons and tons, because you would hear one of the SOPs for one of the ethics committee, they would require you to submit packages, 12 packages, such that every research ethics committee member receives a package for review. But also thinking about environment, how do we control the environment as we conduct research? How do we reduce on cutting down the trees? So technology is evolving, and I know even when it comes to issues of research implementation, you are talking about implementing the research electronically, get informed consent, electronic informed consent. There are all those issues surrounding electronic informed consent, but also when it comes to research institutions, there is a challenge of storage of hard copies. How do we ensure that we minimize on the infrastructures by having research records maintained electronically? So research is evolving and research requirements are evolving, and I guess we need to embrace the changes that are coming up as research evolves. And I think we shall need a lot of guidance documents in regard to control access, protecting participants' confidentiality when it comes to implementation of research using electronic systems. Thank you. Over to you, Professor.
All right, thank you so much. I don't see any other questions in the chat, but as we conclude, I'd like to just ask each one of you to comment on some of these issues that are important for children, because you're consenting for the child, but it's really the parent or the mother in our setup. There are two issues I want us to look at, but maybe I'll ask one question at a time, then ask the second one afterwards, all of you to comment, starting with Dr. Marka Maria and Mr. Guang. Because we have children and the issue of the mother providing consent, and yet in our culture, and I think Maria mentioned it, the community, the husband or the partner, the male partner is the sort of in the community, the leader. And yet in many of our health-seeking behaviors, it's the mother who comes and she's the one who gives consent. So just to really discuss the issue of maternal consent versus paternal consent versus joint consent, and especially in children, because that doesn't apply if it's an adult. Over. Dr. Marka, start us off, then we go through.
Thank you. For minimal risk research, one parent can consent. However, if it's greater than minimal risk, then both parents should consent. However, when you read the regulatory guidance, and by the nature of our communities, you find that at times it's difficult. I mean, the fathers or the fathers of these children do not, usually do not participate in this. So what the guidance says, for more than minimal risk research, all effort should be made to have two parents. However, if you fail, you have to show, you have to prove that at least effort was made to reach out to the father of that child. So the thing is, for greater than minimal, you need both parents. However, if you cannot get the other parent, you have to show that you really tried to reach out to them. Thanks very much.
Thank you very much, Tamwaka. Maria, do you have anything to add to that? And then I'll ask.
I just want to say that as we focus on conducting research in children, we need to be mindful about the cultural requirements. In our culture, the children belong to the men, and usually they have overall say over these children. But the challenge that we have that I want to talk about is men involvement in pediatric research. We need to do, when it comes to community engagement, I guess that is something where we need to focus a lot to make sure that the men understand that these children contribute to new knowledge and also to new drug formulations and new information. How do we have these children take part in research with their parents knowing that they are taking part in research? And I think the other important thing is to think about the informed consent issues. We have this guidance that give us flexibility, but when it comes to litigations, it becomes a bigger issue than what we think. So community engagement needs to be strengthened at that level. That's what I wanted to add, Professor.
Thank you very much, Maria. And then Councillor Oguang, any additions?
Yes. First of all, I want us to appreciate that the research stakeholders, like I had noted them, need a lot of time to do a lot of awareness. Because for us legally, one, the issue of customs are supposed to be applied, bearing in mind that Uganda as a nation has laws. Although you are allowed to use them, they should not be abusive to our state laws. We need to bring that into the understanding of the people who might jeopardize the maternal consent. We need to bring it clear to them that there are also no issue of ownership about children. We have always misunderstood children to be belonging to the fathers. Legally speaking, you can never own a human being. Children, you can only talk about their custody, talk about the parental responsibilities. What should a parent do? But nothing like ownership. Neither father or a mother will talk about the ownership of a child, but we shall talk about what is your role as a parent, and then who takes custody. And those are some of the orders that courts give. Courts have never given anything to do with the ownership. So all of us have parental responsibility in case we have a child. Secondly, I want to note that there are instances where the consent of the mother is only wanted. For example, if it is a pregnant mother, the mother is pregnant, a fetus by another person, but the research is being conducted entirely to address the health issues of the mother. On such circumstances, it is only necessary to have the guidelines allow you to obtain consent of only of the mother. Then the other circumstance where you can obtain the consent of the mother only is where the pregnancy has resulted from maybe incest or defilement or rape rather. For those cases, it is the guidelines allow us to obtain the consent of the mother. But I think we need to do much. Let us know that the law makes human beings equal. So let all of us should be allowed to consent without that negative treatment from clans, from maybe cultural institutions and their like.
Okay, thank you so much. And then lastly, before we end, we have 5 minutes. So when you respond, please be brief. We didn't discuss the issue of group consent. I think we all know the challenges of getting consent in our populations. The consent is about 10 pages in English. Then you transfer to our local languages. And in reality, who's going to understand 20 pages? Make an effort to read the consent to the mother or the caretaker or whoever's going through the consent. But it really is a big issue for us in developing countries. So the question I have, just as a something to think about, what do you, in brief, because we have 5 minutes, what do you think about group consent for these studies, especially for children, if they're all having the same condition? Could it be that we recommend a group of mothers together, read the consent, they ask their questions in a group, and then obviously they consent individually? Over. Again, I'll start with Dr. Mwaka and then go through. Over.
Okay, thanks. Thanks very much. When you talk about group consent, I'll call it a misnomer, because what happens, basically, it's that the disclosure of information is done in a group so that people understand, they discuss, have an iterative discussion, maybe with role plays and demonstrations, illustration, etc. However, the final consent somebody has to give to participate in research or for their children to participate in research is done at an individual level. You can, yes, disclose information in a group, but the actual consent, what we call the declaration, is done individually. Thanks very much.
Maria, your thoughts before we conclude about the group?
Right.
Or as
Thank
I've
you.
been told, group discussion and individual consent. Over.
Thank you, Professor. I guess there are issues to do with informed consent requirements based on international and local guidelines that we cannot run away from, but also we need to make sure that all the required information appears in the consent. The good thing, copies are given to the participant as a requirement, and they can continue reading the consent in case of anything. They can always come back to the teams to ask questions. But I guess the best mechanism would be to, how do we simplify ensuring that these participants understand the information? So there are mechanisms of simplifying informed consent information. For example, we can do videos. Of course, when a researcher does a video, it is supposed to be up, it is supposed to go through the approval process. We can have pictorials like flip charts to make sure that participants understand. Because what Professor is saying is true. For you to sit down with somebody who came for care, for health care, put them aside to read a 20-page consent, sometimes they are not even listening. So we can also have another mechanism of like maybe having a discussion about the study, then you fix an appointment to make them come back so that they come when they're prepared to listen to you without having other worries that they may be having about their health, about home, about how they're going to travel back home, some such issues. So I think we may not run away from the informed consent requirements, but we may also want to have a mechanism of simplifying and making sure that participants understand the information. Thank you.
Thank you. We've got 2 minutes. Councillor Ogwang, in 1 minute, if you can just summarize any addition you'd like to say about the group.
Yes, all has been said, but legally speaking, like I already said, this is a child of the law. Documentary consent must be in the video. We can learn together, we can share, discuss, but the documented one must be in the video. That's what the guidelines provide. But when we are reducing this paper, it is okay that we should reduce them. It is recommended. But let us reduce them without affecting the pertinent issues that must be brought out for purposes of the informed consent. Thank you.
Thank you very much. I want to thank all our presenters for the excellent presentations and key discussion items about research and ethics in children. We've come to our time, end of our time. We want to thank all those who've actively participated, who've listened, for those who've been able to ask questions. Thank you so much. And we really know that this is still an ongoing discussion and ongoing debate. We really thank you for your time. At the peak, we are over 100, but I think because of time, we've reduced. So thank you for your interest in this very important topic. And we want to thank you from SNIP Africa. This webinar series is coming from SNIP Africa, and we thank you for participating actively. And we want to wish you a good rest of your day or a good evening. Thank you so much for your participation. And we thank you very much, our presenters, Dr. Mwaka, Ms. Maria Musisi, and Councillor Ogwang. Thank you very much. The webinar is officially closed. Bye-bye.